Hi. Uh, Today, the lecture is going to focus on medicated opioid treatment for addiction. And next week, we're going to talk about some new processes, some alternative treatments where the efficacy has not been researched yet because they're so new. But there are some other possibilities on the horizon. One of the biggest debates and concerns for both therapists, doctors, and clients is whether to taper off maintenance drug therapy so that the patient is totally clean. And that's a debate because there's been a lot of different and varying research on this subject. Some research shows that, yes, in many ways, being totally clean of opioids is definitely a healthier lifestyle, both physically and emotionally. So using supplemental medications like methadone or Suboxone or other things for help with the detox process and help in gradual tapering off of all opioids is one option. The other option is using them as long-term treatment, and the argument for that is less relapse. And relapse is a strange word because in most cases they are on some opioid medication. However, they are usually very different. They are not illegal. They are prescribed, they are monitored, they have over a 24-hour lifespan and then a half-life. But there are drawbacks as well, and we'll talk about those. So we're going to look at all of the various medical treatments available, that most popular ones. Many of them go by other branded names, but we're going to look at the most popular names. One thing I must stress, being a therapist myself, is that all of these treatment programs need to be combined with long-term therapy. So even if the client is moving through a process of detox, medicated treatment, and then a tapering off, therapy, counseling, should be ongoing throughout the process. Yes, it is very difficult and usually not even offered during detox, but there's usually some form offered so that clients know what's expected and withdrawal symptoms and how that's going to be handled and what's going to happen next and what the process is and things like that. So much more difficult during the detox process. And many people see the client as being in a crisis state during detox. And then definitely should be a part of the treatment program, should be part of the tapering off program, and it should continue after the client is off of all opioids for at least a year. Because relapse does occur more often when the client is not on any supplemental medication. One of the problems is also that, let's say a client goes through detox and then they get on some type of opioid replacement therapy, or it's also called opioid substitution therapy. But opioid replacement therapy. And then they taper off that, or they're still taking it, like methadone or Suboxone, and they and they want that high, or they've tapered off completely and they go into relapse. One of the big mistakes is that many people take the same high dosage of heroin or pills that they had built up to, and that creates an immediate overdose because they had detoxified and their body had not built up a tolerance, which it would have to do once again once it has been taken off opioids. So a lot of overdoses come from relapse after either the client is moved to some supplemental treatment or tapered off of all medication. So let's look at opiate substitution therapy or maintenance drugs. And I just highlighted some very specific things. The two primary struggles with getting a client into this is a fear of withdrawal symptoms. But when we're using opioid replacement therapy or opioid substitution therapy, two names for the same thing, the detox is much more subtle because we're just changing the type of drug that is being used to a much more manageable medication. And the second problem, other than the fear of withdrawal, is basically the desire for that euphoric feeling and then feeling empty without that. Retraining the brain to find happiness, fulfillment, and satisfaction, well-being. One question is always whether to taper off or not. So here we have some of the choices are available for long-term use as opiate maintenance drugs. Others are available for short-term use to assist in opiate detox, while others are recommended for short-term use, yet used for maintenance purposes anyway. And there are benefits and dangers to each of these medications, and we'll talk about those. So opiate substitution therapy itself is the process of replacing the abused opiate, such as heroin or pain pills, with a longer-acting and less euphoric opioid. This would be something like methadone, Suboxone, which is taken under medical supervision. The main idea behind ORT is that the opiate addict would be able to regain a normal life while being treated with a substance that prevents them from experiencing severe withdrawal symptoms, and it reduces drug cravings, but it doesn't provide the same euphoric high. They're able to maintain a normal life functioning, a job, without the craving. So it also decriminalizes, and we've talked about the criminalization of addiction and illegal drugs and people stealing things, everything that goes into the criminalization process. So it also decriminalizes this whole process. They usually go in to a clinic at about between 5 and 7 a.m. pretty early so they can get on with their day and take their medication. They are observed taking their medication. There may be blood tests involved and things like that. Some of the drugs we're going to look at right now: methadone, buprenorphine, Suboxone, naltrexone, They have all been approved by the FDA for treatment of opiate addiction. There's also some recent breakthroughs with the drug naloxone. So let's look at the longest treatment medication, methadone. Lots of methadone clinics in Western Pennsylvania. I have mixed feelings with methadone and other medications. And this is just my personal belief, and I believe that as a therapist, I should work with a physician and the client, and we should really see what is best for the client. I personally do recommend some help with detox. So some type of alternative medication to help with detox, followed by long-term counseling and therapy, addictions counseling, because it's not just dealing with cravings. People have changed their entire life structure to accommodate an addiction. Relationships, finances, jobs, cognitive remapping structures. And it's going to take at least a year to deal with those changes and to make some positive changes back. So I definitely support some help through the detoxification process. I definitely support counseling no matter what process is chosen after detox. I personally prefer, a gradual tapering off of all meds, while at the same time exploring comorbidity, co-diagnoses, and treating them as well. And those may require some medication or not. However, if the client seems to be in crisis and in danger of a relapse, definitely a long-term medicated treatment, a substitute, would be much preferable to heroin, an overdose, and going back to a criminalization process. So as a therapist, I would not tell the client what to do. I would gain an understanding of where the client was, work with a medical doctor in that process, do ongoing assessments, see how a process is going. If it's monitored to an extensive degree, then it's very easy to move back on a medicated long-term process without moving into relapse. One of the big mistakes of treatment centers is trying to save some money or not providing a high enough dosage of the substitute medication. So if they don't provide a high enough dosage of methadone or one of the other medications, the cravings will still occur, and then they're not only going to relapse, they're going to relapse while on methadone, which can definitely result in an overdose. So when we're thinking about methadone, remember, it's got a long life in the system, up to 3 days or longer. And when we're talking about that pyramid and the long-term presence in a physical body, it's very easy to overdose. It also suppresses coughing and as well as breathing, and taken in high enough dosages. And if somebody combines it with another medication like a benzodiazepine, like Ativan or one of the other benzos, it can stop their breathing. They can overdose with that combination, and we see that a lot. So it's also methadone, also known under the names Simorin, Dolafine, Imidone, Methadose, Phiseptone, Heptadone, among others. It's a synthetic opioid developed in Germany in 1937, like we mentioned before. It's a synthetic mu-opioid receptor agonist administered orally in liquid, tablet, or dispersible tablet formulation. One of the problems is that if the tablets are provided to clients, it can be mistaken for other medications. Children have overdosed on them. They dissolve rapidly, normally. Usually, they are given under supervision, so they're given a cup of juice or water, paper cup. The pill is dropped into that. They dissolve rapidly and they drink it, and then they cannot hoard the pills and take them later or in higher dosages. So it's also a safety measure. The pills can't be sold then, or taken by somebody you shouldn't take them. So Eli Lilly and Company, the methadone's ability to relieve the opiate withdrawal syndrome was noted as early as 1947, so that would be right after World War II. When it was introduced in the U.S. by Eli Lilly and Company, within 2 years it became the preferred medication for detoxification at the National Narcotics Hospital in Lexington, Kentucky. So that's a long time ago, right after World War II. Of course, a lot of soldiers had been given morphine and other medication during the war. It was not until 1964 when scientists at the Rockefeller Medical Research Institute began to evaluate methadone maintenance as a means of long-term medication-assisted treatment for opiate addiction. So in the 60s, that's when the big shift occurred to using methadone daily, once every 24 hours, for long-term treatment. And I mentioned the financial concern. This is the cynical side of me. There is definitely a financial benefit for methadone clinics to keep clients on medication. There's a lot of money in methadone treatment centers, and that's why I think it's really important to work with a therapist, a medical doctor, perhaps not one even outside of the methadone clinic, to get an accurate perspective on what is truly best for the client. And many clinics are very positive, and they can save a lot of lives. But I would just make sure that my clients were doing what was best for them in the long term, whatever that might be, whether it's long-term therapy or tapering off, whatever's best for the client, and every person's different. And like I said, methadone can be dangerous if mixed with other medications. I just highlighted some of those things that I thought were important, and let's talk about Suboxone and buprenorphine. Um, and so we have a combination here of buprenorphine, which is a semi-synthetic opioid, and naloxone, also known as Narcan, which is what they use to save people when they've overdosed. So Suboxone is a combination of those two medications. The first semi-synthetic opioid, and the second used to block the effects of opioids, especially overdosed. So here we have this combination. When buprenorphine is used alone, it's used in a very similar way to methadone. But I rarely see that personally. I usually see Suboxone. It's also available under Subutex, Suboxone, and other means. Buprenorphine was marketed in the 1980s as an analgesic, and in 2002 FDA approved Suboxone and Subutex for detox. Suboxone is what's called a partial opiate agonist. So there's a lower risk of overdose and addiction than methadone, and of course, we know that part of this is Narcan, so there's definitely a lower risk for overdose. The drug tricks the brain into thinking that it has a full opioid dose, and then it prevents the withdrawal symptoms from commencing, when in reality it's a partial dose. And Suboxone is a long-acting opiate with a 24 hours plus half-life, so a day and a half basically. So it only needs to be taken once daily, but it can also build up in the system. You don't want to mix it with other medications. Suboxone clinics are kind of the up-and-coming treatment centers. A lot of methadone clinics are offering either one. And then we have naltrexone. Naltrexone should only be used after detox because you want the least amount of withdrawal symptoms during the detox process. And the best way to get lower withdrawal symptoms is through methadone or one of the other substitutes with a longer life within the body. But naltrexone would actually initiate withdrawal. So you want to use that after detox and withdrawal. It's an opioid receptor antagonist used primarily in the management of alcohol dependence and opioid dependence, marketed in generic form as hydrochloride salt, naltrexone hydrochloride, sold under trade name Revia or Depade. Naltrexone works by blocking the effects of opiates in the brain, and naltrexone is not a narcotic. In fact, it will actually not only block, but it is able to block the reaction from the part of the brain that produces feelings of pleasure when opiates are taken, shown to reduce drug cravings in some people, but not all. Not an opiate replacement drug. Its primary use is to help those who have already stopped using drugs and not return to them. And I want to talk a little bit about just a few other things. There is some more recent research for what's called a heroin vaccine. In May 2013, a study released by Scripps Research Institute showed that a heroin blocking vaccine is now ready for human trials. I looked, I wasn't able to find a recent publication on whether that was successful or not. Senior study author Kim Janda says the vaccine causes the body to produce antibodies against heroin and its psychoactive products. These antibodies circulate in the bloodstream and neutralize any of these substances they encounter before they reach the brain. And they referred to it, it's like the old 80s game Pac-Man. That's very promising. There's one other thing I'd like to mention, and that's the rapid detox process, or the ultra rapid detox, a process by which withdrawal process is condensed into a very short period of time, anything from hours to a couple of days. But what they'll do is they'll normally sedate the client, either put them to sleep or heavily sedate them, infuse them with a multitude of drugs such as naltrexone. This accelerates the detoxification process while the client withdraws, they're sedated or asleep. Speeds up the return to what many consider normal opioid functioning, but I'm not sure about the efficacy of this process. Yes, it does speed up the withdrawal process. It's often problematic. There's high relapse numbers in this process. I think it needs to be monitored quite a bit. It could have some pretty serious physical side effects, heart racing, blood pressure, all kinds of things could go wrong. Many complain that they still experience withdrawal symptoms afterward. So I'd like to hear if any of you work in methadone clinics, Suboxone treatment centers, detox centers. I'd love to hear about your personal experience with clients and the agencies and how you think that is going, and the pros and the cons, and what your personal beliefs are. I'm kind of in the middle, and I just kind of look at what would work best for the client with long-term therapy and intensive monitoring. So that's my take on the subject as a whole, and I would really like to hear about either your opinions or if you have any experiences, your experiences. Thank you.